Next is Dr. Kiranjit Singh. He couldn't make it. So this will not be, marks will not be given in this one. But I'll play the video anyhow.
The way a four-wheeler is more safe than a two-wheeler, similarly, a four-claw iris claw lens is much more safe than a two-claw lens, which was basically designed by Dr. Jan Wurst, and we have modified into a four-claw. Let's see its application in one of the cases. This is a case of subluxated iris claw lens, which was primarily done as a secondary case around 30 years back in a case with a large iris coloboma. So the offending lens is removed and a little bit of vitrectomy is done, and this is the four-claw lens we have been talking about. This is inserted through a 5mm incision. It is held with a Clayman forceps or a vertical forceps, and iris is engaged with the tip of the needle and enclaved through the claw. So now the two claws have been fixed. Now it is time for the third claw to be fixed. So we usually use a 27 gauge needle through a stab incision given with a 0.8 diamond blade. It is held with a Clayman forceps, and this is the third claw which is being fixed. Then IOL, but a IOL device. It will help in anterior chamber reconstruction also. So in this case, we are pulling the iris, edge of the coloboma iris, and we are enclaving it in a four claw, and this will do little bit of pupilloplasty as well. So care is taken not to enclave the edge of the iris, but the flat surface of the iris. So now all the four claws are fixed. This lens does not exhibit any pseudophecodinosis. So there is time for doing anterior vitrectomy to clear off the interior vitreous, which has so many opacities, and care is taken when the vitrector probe is withdrawn. It should not.
So I think it's a bad neuroinnovation by Dr. Kiranjit Singh. Dr. Mohan Rajan is busy in OPL, so he said, excuse me, we are just going to play his video only, but no marks.
A nick in time saves 9. Just to show you a Medicel, a blue or a green injector, I'm trying to put an Invistar lens. But what is happening is the trailing haptic is getting caught in the space between the silicone plunger and the cartridge wall. If you try to remove that or pull it out, that can be damage to the haptic and you need to explant the lens. There's another patient who's had an in-focus lens, and you can see how I'm trying to do the implantation of the lens with the Medicel green injector. There's nothing wrong with the lens, but you can see the trailing haptic is again caught in the space between the plunger and the cartridge wall. I just use a 11 blade to open up the space, to open up the cartridge. This is called ocular episiotomy. Once I make a nick on the cartridge, there is more space for the haptic to be released, and the rest of the problem gets solved easily without any deformation of the haptic or the optic. You can see, just to demonstrate an hydrophilic lens using a Medicel green injector, how the trailing haptic is getting caught and getting trapped. And I'm doing a ocular episiotomy again, opening up the cartridge with the 11 blade, and you see beautifully the haptic gets released very nicely without any damage to the haptic or the optic. So this is a very simple method, very elegant method of taking care of the problem. This problem is more common than what you can imagine, and it can take you by surprise at the end of the implantation, and very common in green or the blue Medicel injectors. The take-home message is a nick in time saves 9. Ocular episiotomy is the way to go.